Yes.
Good evening, everybody. Welcome to the first PG clinic organized by IAP Cochin branch. And I thank Dr. Jayakumar for accepting the invitation even without thinking. And he said he is there. So that this is the first of the series, and we are planning to have it on a regular basis. And I now invite Dr. Narayanan, State President, for the inauguration of the PG clinic. Thank you.
Good evening to you all. Dr. Pramod, President of IAP Cochin branch, Dr. Jayakumar C, Professor, and who is going to take class today, Dr. Shiji, my dear friends in IAP, dear postgraduate students. Today we are launching the PG teaching program of from IAP Cochin branch. Of course, the first session is at Government Medical College Thrissur, Kalamassery. And PG teaching program is one among the 40 action plans of IAP Kerala this year. And we already have teaching programs in Calicut and Thrissur. And we had some neurology teaching programs. And now it's good that Cochin has also started. Congratulations to Cochin branch and the postgraduate institutions in Cochin. And definitely we'll be having this session regularly. And all the postgraduates, not only from Cochin, Ernakulam, or from all over Kerala, will be benefited from this. So I'm very happy to formally inaugurate this teaching sessions. Thank you. Have a happy learning, happy teaching. Thank you.
Thank you very much, Dr. Narayanan, for inaugurating. Next, I request Professor Jayakumar, who's going to chair this session, to take over. Thank you.
Most respected President of IAP Kochi, Dr. Pramod Warrior, Secretary Dr. Sajid John, Treasurer Dr. Deepa, and distinguished professors, we have Dr. Bani Vikramampilla, Dr. Josh Paul, Dr. Shiji Jacob, and Dr. Rekha Sakaria, and my dear postgraduates. I'm very happy to chair this session because you know that this is my job. My job is to chair the PG classes. You know, and I am all the more happy, and for one reason is Kochi Cooperative Medical College is presenting a student of a Kochi Cooperative Medical College is presenting a case. Last time I had an encounter with the Cochin Cooperative Medical College at MOSC Kolancheri, and the students of that medical college perform very well. So from Dr. Shiji Jacob, I heard that that's the way in which she teaches students. She has told me that, sir, teaching is a passion for me. And I have the very best from the students of Kochi Cooperative Medical College. And Dr. Jocelyn. Are you Dr. Jocelyn? You are going to present a case. Yes, could you please share your screen? Dr. Jocelyn?
Sir.
Can you hear me?
Yes, sir. Sir, slide.
You adjust your camera a little bit. We cannot see. I cannot see your face. Okay, now it's okay. Please share your screen. Start presenting.
Sir, is it visible now?
So it's my habit to, I will intervene in between. Throughout, okay, most probably I will intervene. Even though I am a little bit tired because I had a hectic program today morning, starting from PG class 8 o'clock, and then a teachers training program, and then another meeting. So irrespective of that, I will intervene. Okay, so that's my practice.
Okay, sir. Presenting the case of Aiden Cyril, 8-year-old male.
Share your screen. We cannot. I cannot see your screen.
Okay, sir. എനിക്ക് ഒരു minute, sir.
I can't see. I can't see.
വരും sir, ഇപ്പൊ വരും.
Oh, okay. What's the name of this child? First slide, please.
Okay, sir. ഒരു minute, sir. 1 minute. Aiden Cyril.
Okay. How old is he?
He's 8 years old male child from Fort Kochi. The informant is mother and the history is reliable.
So that's very important. That means always say the native place of the patient and from which, what is the distance between the native place and the hospital. So this is beyond pediatrics, because if the patient is from far away place and suppose we are sitting in emergency and sometimes child may have trivial illness, mild illness, but in due course, you know that in due course something can happen to the child, then patient cannot come back. So for that matter, always note the native place of the patient and also the distance between the native place and the hospital. So that's good. Okay, proceed.
And coming to the presenting complaints of vomiting for last 2 days, complaints of fever for 1 day, complaints of fast breathing for 1 day.
So vomiting, fever, and fast breathing. Okay.
Coming to the history of present illness, child is a known case of developmental delay. He was relatively asymptomatic 1 week back when he developed vomiting. There was 2 to 3 episodes per day. It was a projectile vomiting.
So could you please mention the grade of this disability, whether child was grade 4 disability or child was able to walk around, child was able to read? How much development delay was present for this patient?
GMFS 5, sir.
Pardon?
GMFS 5 classification, 5 class,
Okay.
sir.
That means, what do you mean by that?
Child is not able to mobilize without a manual wheelchair.
Okay. Good. Okay, then so child had severe development delay. Okay, then
Yes,
and then what happened to the patient?
And he developed 2 to 3 episodes of vomiting that was projectile in nature, and there is associated history of nasal regurgitation of food, and history of occasional cough was present.
Okay, was it bile stained?
It was not bile stained.
Okay, why is it important to ask about this question?
Bile stained vomitus means lesions below the ambule of water.
Could you please say simply?
Ma'am, sir?
Could you please say it simply that other people can also understand?
If it is bile stain, it indicates some lower GI causes.
It's a surgical cause.
Surgical causes.
Surgical cause.
Like obstruction.
That's the reason why you should always ask for this bile stain vomitus. Okay, then what happened?
From the next day, he developed a fever, which was high grade.
No. Then you have to find out the reason for this vomiting. What is the reason for this vomiting? Did you ask any question to know whether any other problem with this child? Any history of constipation for this patient associated with this episode, or any history of any other significant problem along with this episode? You elaborate this vomiting.
And he had fast breathing and fever in the next day, sir.
No.
Other than this vomiting, there is no
any other GA symptoms for this child?
There is no history suggestive of any abdominal pain, no history of any loose stools or blood in stools, no history of any increased frequency of micturition, no history suggestive of dysuria, and there is no history of food given from outside to the child. There is no history of any yellowish discoloration of urine or body.
Then?
And there is no history of constipation.
That you have told. Then? Anything else?
And child had associated with the vomiting. No history of any fall.
1 second, Praveena. ഞാൻ പ്രവീണ, ഞാൻ മീറ്റിംഗിൽ കുറച്ച് കഴിഞ്ഞിട്ട് വിളിക്കാം. ഞാൻ മീറ്റിംഗിലാ. Hello?
Sir.
Yeah. Any history of rashes for this patient?
No history of rashes.
Did you mention about that?
No, sir.
No. It's important to ask for rashes. Any history of joint symptoms for this patient?
No
When you
history
take
of
the history of a
arthralgia.
patient, you have to go beyond the system that is affected, and you have to ask questions to roll out involvement of other systems also. Yes. Then, any history suggestive of any headache or alteration of sensorium, any seizures along with this episode?
No, sir. There was no history of any abnormal movements, and there is no history of any alteration of normal behavior during these episodes.
Then what happened?
No history
Then
of
what
any
happened?
increased irritability.
Then what happened?
And from the next day, he developed a fever, which was high grade. That was not associated with the rigors and subsided with the medication. And child was well in between the fever episodes.
Do you have any idea that which medication they have given for this fever?
Paracetamol was given.
Acetaminophen. So, so are you in favor of giving NSAIDs for controlling fever? Some people used to give mefenamic acid, some people give ibuprofen, etc. for controlling fever. What's your opinion about that?
It's better to avoid methyl-ibugesic.
Why?
Because of the renal toxicity.
And?
Liver injury.
Okay, then.
Hepatotoxicity.
Then, any side effects for NSAIDs in general?
It can cause bleeding. If it is an overdose.
Especially this ibuprofen decrease addition of platelet. Okay, then. Then. In COVID season, is NSAIDs are advisable? Now there is a pandemic is going on. So do you advise NSAIDs to control fever?
Increase the chance of MISC with NSAIDs.
Because of MISC, why you are not interested, why you are not giving NSAIDs during COVID pandemic? You might have heard the toxicity, the complications associated with the use of NSAID. Is it like that?
Yes, sir.
Yes. So,
increase the chance
so in control for controlling fever, better to use only acetaminophen rather than other NSAIDs. So it can cause. So what is the complication they can develop if patient is having asthma? So it can also precipitate asthma. Isn't it like that?
If
whether NSAIDs can precipitate asthma?
Ibuprofen can precipitate asthma.
Okay, so they have given acetaminophen with that, but then what happens to the child?
Yes. And the fever subsided, and the child was in between fever episodes.
Pardon?
And the child was well in between the fever episodes.
In between, child was well.
Child was not sick looking according to the according to the history, and mother noticed a history of fast breathing. That was gradual in onset, and that persisted even after fever subsided. And according to history, there is no history suggestive of any chest in drawing, no history suggestive of any grunt, and child had only occasional cough. And
so what is the relevance of fast breathing in a child who is having fever and cough?
It can be suggestive of pneumonia.
Okay. What are the WHO cutoff rate to say suggestive of WHO cutoff for pneumonia?
Okay.
For various age group?
Less than 2 months, more than 60. 2 to 12 months, more than 50. 1 to 5 years, more than 40 respiratory rate.
More than 5 years?
30.
Some people say it is 20. What is your respiratory? So some people say 20, not 30. So 60, 50, 40 and 20. 20 is the cutoff rate. Normal respiratory rate is approximately 60. Half of this. So WHO has taken double the normality as cutoff rates. Okay. So in addition, whether this child had any other symptoms, you said there are no chest drawing. What do you mean by chest drawing?
Chest drawings are the that increase the work of breathing.
Which part of the body? This lower chest drawing?
Lower chest drawings, sir.
So what do you mean by that? What happens to the chest when what do you mean by indrawing? Normally what happens when you take a deep breath?
The intrathoracic pressure.
No. What happens to expansion? Whether it goes in or goes out? Normally.
Goes out normally.
So in chest drawing, what happens?
Goes in.
Goes in. So the parents has told you that there is no chest drawing with this episode. Then whether this child had any other red flag signs of pneumonia?
There was no history of any decreased food intake, no history of any lethargy, no history of suggestive of any abnormal movements.
Then what are the other red flag signs that you specifically ask?
cyanosis, any discoloration of tongue,
Okay, bluish discoloration.
bluish discoloration of body or face.
Then
Abnormal sleeping.
Okay, that you already told. Anything else? Any other peculiar noise children used to produce when they have this?
Grunt.
Could you please imitate a grunting respiratory noise? You're correct. So what is the significance of this grunt?
Grunt means the child is trying to prevent the alveolar collapse by increasing the end expiratory pressure.
That is good. So they are trying to increase the end expiratory pressure. They are creating positive end expiratory pressure to prevent a collapse of alveoli. That's very good. Okay. So this child didn't have any of this this red flag signs. Good. Okay. Then proceed.
All other associated with vomiting, there was no history of any loose stools, no history of any blood in stools.
That you already told. And then next. No. So beyond that, do you want to ask any questions to this child? Any congenital condition for this patient? Any history of choking episodes? You said this child is a child with a developmental delay.
Yes,
so
sir.
which complication you anticipate in this patient?
It could be there's a high chance of aspiration pneumonia.
With that in mind, do you ask any question?
Significant history.
With that in mind,
there was a history of nasal regurgitation of food.
That is present. Then
history of occasional cough was present, and mother noticed while he is feeding the child there is a difficulty in swallowing.
So this child is having swallowing difficulty, and
yes,
whether this child used to choke when they are giving feeds, whether that is there.
Yes, sir. The child is having recurrent episodes of choking for the last 6 months, and
whether
since last
choking
6 months
is with on solid food or liquid foods.
It was mother is only giving semi-solid food.
Okay, and the child used to have this choking episodes while they are giving feeds.
Mother noticed.
What do you think about this patient? After hearing the history in a child like this, what's your impression? What are your thoughts about this problem?
There can be. Normally in cerebral palsy children, there can be associated pseudobulbar palsy.
So this child may be suffering from pseudobulbar palsy. Okay, good. Then proceed.
Pseudobulbar palsy. And for last 6 months, he's on RT feeds, sir.
This child is on RT feeds.
RT feeds for the last 6 months.
Okay, and they are giving RT feeds only because child cannot swallow and child used to choke when they are giving feeds.
Yes, sir.
Okay, and then other than this, any other chance for you said your impression is the child is having pneumonia because of the fast breathing, and so then and the reason for this pneumonia is aspiration pneumonia. Any chance for any other pneumonia for this patient other than this aspiration pneumonia? Any chance for communicated pneumonia?
He's an immunocompromised.
What do you mean child is immunocompromised? How can you say child is immunocompromised?
No, sir, no.
No, child is not immunocompromised. Child is having development delay. How can you say the child is immunocompromised? What are the features of what are the clinical features that you see in a child with an immunocompromised situation?
There is more chance of staphylococcal pneumonia with a severe complication.
So tell me the clinical features suggestive of an immunocompromised child that you see.
Failure to thrive, developmental failure to thrive. There can be skin lesions like extensive molluscum, tinea, signs of vitamin deficiencies.
Other than that,
bilateral parotid swelling.
Yes, then.
Generalized lymphadenopathy.
Okay, then.
Organomegaly.
That's not no. Other any history of meningitis, any history of liver abscess, any history of osteomyelitis, any history of chronic diarrhea for this patient?
Recurrent history of ear infections.
Any recurrent pyoderma?
Recurrent abscess.
Whether this child had any episodes of meningitis, osteomyelitis, liver abscess?
Nothing, sir. Nothing.
So that means you cannot say that child is an immunocompromised host. Okay, you cannot say like that. Then proceed. Then any other reason for this pneumonia and what type of pneumonia you are expecting? So any chance for hydrocarbon exposure where the child had consumed hydrocarbon? Any history of accidental ingestion of hydrocarbon?
No, sir. The child is on
nobody. So because child is on RT feeds and the parents are very careful. So instead of water, they might not have given this hydrocarbon. Okay, proceed. But younger children with pneumonia, you have to anticipate that and you have to ask questions like that. Any history of pyoderma for this patient?
No history of
No
pyoderma.
history of the pyoderma is also present. Child is having pneumonia. Which organism you suspect?
Staph aureus. We have to
Staphylococcus
suspect.
aureus. Okay, then any other questions that you asked, whether anybody is having chronic cough, any adolescent is having intractable cough that lasted for a month or like that, in that situation, which condition you are suspecting?
GERD.
No.
In this
A
child,
contact with an adolescent or a young child who is having continuous bout of cough, and this child is having pneumonia.
tuberculosis.
Huh?
Tuberculosis pneumonia. Okay.
Tuberculous pneumonia. So tuberculous pneumonia, how common is tuberculosis presenting as continuous cough in an adolescent or a young child? That is not common. So tuberculosis is one of the last diagnosis that you will consider. Usually that much amount of frank tuberculosis is not there in our country, in our state. Not in our country, in our state. Intractable cough, continuous cough, bout of cough in a sibling, and then this child is also having cough.
Pertus.
Exactly. That's good. Whooping cough. Whooping cough is the correct answer. So any history, any contact with the whooping cough?
No, sir. No history of any contact with the virus.
No history of suggestion of any pyoderma. And nobody is having any viral, no history of rashes for this patient that you are already told. So it's unlikely to be a viral pneumonia, no chance for hydrocarbon pneumonia. So the possibilities for this patient is aspiration pneumonia. Isn't like that?
Yes, sir.
No, the cause of this may be a GER or because child might have swallowing difficulties.
Having bulbar palsy.
So pseudobulbar palsy. Then so there is no congenital condition for this patient. So chance for chlamydial infections or mycoplasma is also unlikely. Okay, then proceed. So communicable pneumonia is still an option for this patient. That's another option. Aspiration pneumonia is the best possibility, but communicable pneumonia also you have to consider. Okay, let us see whether when you come to the immunization history, the child is immunized for these. Then proceed.
And as to say a case of developmental delay, I would like to start from the antenatal history.
Okay.
Coming to the antenatal history, child is the firstborn to non-consanguineous marriage. Mother was 25-year-old at the time of delivery, and mother's blood group is B positive. There is no history of any abortions for the mother. Coming to first trimester, there is no
medical history.
Sir.
Maternal medical history. You're coming
to
later.
In first, yes, sir. It's coming.
Okay. Could you please tell me the maternal medical history?
No history of drug intake.
No.
Other than folic acid.
Prior to conception, was she suffering from hypothyroidism? Was she suffering from any other significant medical illness?
No history of any diabetes mellitus, no history of hypertension, no history of hypothyroidism for the mother.
Psychiatric disorders, seizure disorders.
No history of psychiatric disorders. No seizure disorder, no psychiatric disorders.
Okay, then obstetric history. You said there is no abortion. How many years after married life she conceived? Any history of treatment for infertility?
It was a spontaneous conception and conceived 1 year after marriage. There is no history of an infertility.
Paternal medical history?
No drugs other than folic acid was taken.
Paternal medical history?
Paternal.
What's the relevance of paternal medical history in a child like this, or child is having chronic infection? So you have to ask about the paternal medical history also. This father may be suffering from retrovirus infection.
Okay.
He might not have revealed that.
Okay, sir.
So unless you ask for that, you may miss a important point. Fortunately, now retrovirus infection is not a significant problem in our country. It was not like that yesterday years. So for that matter, you have to ask about the paternal medical history also. In addition, VDRL, syphilis, he might not have revealed. Okay, agreed that intrauterine infection is present in a different way, but retrovirus infection is not like that. So unless you ask for that, you may miss. So it is important to ask about the paternal medical history also.
Okay, sir.
What's your treatment? What's his job? And what's his job? Whether he's traveling frequently?
He's a driver.
Okay, then all the more chance. So there is high incidence of retrovirus infections in drivers. That everybody know. Isn't like that?
Okay, sir.
There is high incidence of retrovirus infections in drivers. Okay, so in all patients, you ask about this maternal medical history, paternal medical history, and obstetric history, and any other surgical history for the mother? No surgical history. No, yes, come to the trimester history. Firstborn child. Okay, then.
Okay, in the first trimester, there is no history of any fever with rashes. no history of bleeding PV. Mother has taken folic acid tablets post-conceptionally. There is no history of
so suppose I left to you, when will you advise folic acid to your mother?
Ideally, it can be taken 3 to 6 months pre-conceptionally.
Yes. Why do you want to take folic acid pre-conceptionally?
Pre-conceptional folic acid decreases the chance of neural tube defects.
Okay, so proceed then.
Okay, there is no history of any fever with rashes, no history of bleeding, no history of drug intake other than folic acid, no history of exposure to radiation, and 2 doses of TT was taken, and mother's HBCG, HIV, VDRL was tested and said to be negative.
What about hepatitis C?
Hepatitis C, she did not.
It's very important to screen for hepatitis C also in the pre-op serology or in the second trimester. So in addition to HBCG, HIV, VDRL, hepatitis C also has to be tested. And you said they have taken 2 doses of TT. Left to you, what's your immunization of choice in pregnancy?
Ideally, the first dose of TT is given at the time of diagnosis of pregnancy, and the second dose is given in the 3rd trimester. If the mother is already...
Do you prefer TT or TDAP?
TDAP can be given.
Not T. Left to you. So what's the choice? Is it TT or TDAP?
TT, sir.
Oh, no. You have to prefer TDAP. TDAP or TD. Krishna Priya says that it is TDAP and TD. So I also agree with her. So you have to give TDAP. Look, at least 1 dose of TDAP has to be given because there is no protection against whooping cough for the newborn if you're not giving TDAP. So whether you can afford or not, so that's as a matter of policy, you have to give TDAP, and you can repeat subsequent pregnancy also. You have to give TDAP and TD. That's an immunization of choice. Now people say that there is no protection against strep pneumo also. If the mother is not immunized against strep pneumo, you can give 1 dose of strep pneumo vaccination also during pregnancy. Proceed. Proceed.
In the 2nd trimester, there was no history of any gestational diabetes mellitus, pregnancy-induced hypertension, no history of bleeding PV. Quickening was felt at 5th month. Adequate weight gain was present for the mother. Anomaly scan was taken, and there was no history suggestive of any fetal anomalies, no history of any polyhydramnios, oligohydramnios, or no history suggestive of any growth retardation in the fetus.
That's very good, but irrespective of that, it's your duty to advise about the extra calorie intake during pregnancy. So which trimester you advise extra calorie intake?
From 2nd trimester onwards, 600
yes. So why don't you want to give extra calories during first trimester?
Because mother will be having hyperemesis in the 1st trimester.
What's the genetic basis of this hyperemesis? Survival benefits. So nature knows that hyperglycemia is teratogenic. So that's the reason why people vomit during 1st trimester. So you have to, from 2nd trimester onwards, you have to give high calories. How much extra calories you give to the mother?
Plus 300 kilocalorie extra.
How much protein?
15 gram extra protein.
How much? Could you please a diet that gives 300 calories and 15 grams protein? A simple diet.
Uppuma 250 kilocalories.
Okay, you cannot take uppuma every day. You cannot take uppuma every day. What is nutrition value of 100 ml of cow's milk?
100 kilocalories.
Milk cows gives 100 kilocalories. Who told you like that?
70 kilocalories.
67 calories. And protein?
4 gram protein.
4 gram protein. 100 ml cow's milk gives 4 grams protein. Who told you like that? So what's your reference?
Sir, I rose milk na sir
cow's milk. People are taking rose milk.
I was heard like that.
People are taking rose milk. Rose milk is coffee use. Rose milk.
Sir, 100 ml contains 67 kilocalorie and 3.3 gram protein.
That's correct. That means if you take 200 ml cow's milk, you will get 134 and 6.6 gram protein. And then how will you, then what about the rest of the calories and protein?
Egg,
okay, an egg gives protein. Okay, you prefer pasteurized milk or milk from the farmhouse? Which milk you prefer?
Pasteurized milk.
Why?
Pasteurization kill most of the there is less chance of brucellosis.
Correct answer. So it's better to use pasteurized milk rather than milk from the farmhouse. So, okay, proceed. So all pregnant mothers should take 300 calories and 15 grams protein from second trimester onwards. You proceed. Anomaly scan was done, it was normal. You proceed. Then whether do you advise calcium and iron?
Yes, sir. Calcium and iron is advised from the second trimester.
Okay. You have to advise. Do you give calcium and iron together or do you give separately?
It should be given separately because
Why?
calcium will prevent the absorption of iron.
Proceed.
Coming to third trimester, there was no history of any bleeding per vaginum, no history of fever or urinary tract infection. There is a history of leaking per vaginum for 16 hours, but there is no history of any IV or oral antibiotics.
Leaking PV for 16 hours. Okay, my God. So
yes.
When will you say there is chance for infection? Is it 16 hours or 17 hours? What's
if it's more than 18 hours, it is significant.
More than 7. Okay. Then proceed.
Mother was not on any antibiotics, no history of any reduced or increased fetal movements, and neurosonogram was taken, and it was said to be normal to the mother.
Neurosonogram.
Sorry, NST, non-stress test was taken and said to be normal to the mother. Coming to the natal history, it was a tame baby, 3.1 kg. History of prolonged labor present from the history, as the mother was started labor pains in one day morning, and she gave birth only on the next day afternoon. And because of there is a delay in the last stage of labor, mother said it was a forceps assisted delivery, and baby did not cry soon after birth. The Apgar is not available, but according to mother, baby was shifted to ICU with oxygen.
So you said baby didn't cry immediately after, but suppose you are in the labor room, what are the things that you might have done to for the baby?
We have to, if we are anticipating high risk labor, we have to prepare before that. According to the NRP guidelines, we have to arrange the instruments in the labor room. We have to switch on the warmer. And if you are expecting, if it's a forceps delivery, it is a high risk labor. We have to anticipate resuscitation. And 2 persons well in neonatal resuscitation should be available at the labor room. And we have to switch on the warmer, keep 3 pre-warmed towels. Ambu should be ready, get ready. And suction, adrenaline, everything should be kept ready. And if the baby is born without breathing, we have to do the initial resuscitation steps.
After cutting the cord and drying the baby, then?
We have to apply 2 strokes on the back. If the baby is not, and give suction, first at the mouth and next at the nose. If the baby is not crying, we have to start the positive pressure ventilation.
How will you give the positive pressure ventilation?
The positive pressure ventilation is given with the...
you won't connect to the pulse oximeter? Will you connect the baby to the pulse oximeter?
Yes, sir. When we are starting the AMBU, the next person who is assisting us should connect the pulse oximeter to the right arm of the baby. And we have to give AMBU. And
what's the frequency of giving this AMBU back?
60 breaths per minute.
Could you please tell me simply?
1 and 2 and 3 and skews.
Sure.
Sorry. Skews 2, 3, skews 2, 3 like that.
Exactly. Skews 2, 3, skews 2, 3 like that. Okay. How many times you use skews?
60 times.
60. You give 60 breath, 60 AMBU back application.
15 breaths after 30 breaths.
30 times. 30 times. How many puffs you will give? Is it 60 or 30? How many times? 6 times only, not more than that. Then, if the baby is bluish, what will you do?
And after 15 breaths, if the baby is...
only 6 times only you are supposed to give the AMBU back. 6 times only, not more than that. It's a golden minute. So you can't, there is no time. It's a golden minute. Suppose if something happens to baby during this golden minute, baby can have devastating effect. So everything has to be completed within 1 minute.
Okay,
then, if baby is blue, what will you do?
We can take ventilation corrective steps. If there is no chest rise, like MR SOPA, like we can reposition the mask, reopen the mouth, can give suction. And as we can go for alternative where we can go for intubation.
And then or any other anything that you will do? Do you count the heart rate?
If the heart rate is more than 100.
How many seconds you count the heart rate?
6 seconds and multiply
and
it
then
with 10.
Which number you want?
10.
10 or 7? At least 7. At least 7. You want a 7. Isn't like that? Should be more than 60.
Yes,
6 into 10 is 60. So you want 7.
7.
Okay. Then if heart rate is less than 60, what will you do? You can
have
give
to
the baby
start,
or
we can start chest compressions. When we are starting the chest
compression, how will you give the chest compression?
Chest compressions are given.
You encircle the baby with
when
both
we are starting
hands.
the chest compression, we have to encircle the baby with our 2 hands. And the lower
show me the position of your thumb. Could you please show me the position of your thumb? Show me once more. I can't see. I can't see. I can't see. Okay. And then how much pressure you apply to displace the thorax, AP diameter?
To the 1/3 of the.
Exactly. Okay. Then how will you give the chest compression?
When we are starting the chest compression.
Louder, please. I can't hear. Hello.
Okay, 1 minute, sir.
1 minute. Connection lost.
Okay, so when we are starting the chest compressions, we have to connect to 100% oxygen, and the ambush should be taken over by the assistant, and it should be given in a coordinated manner. The person who is giving the chest compression should tell 1 and 2 and 3 and.
Exactly, 1 and 2 and 3, and then okay, you proceed like that. You have to proceed, and then okay. So anyway, this baby was shifted to the ICU. Then what happened?
Okay. Sir, slide കാണുന്നുണ്ടോ sir?
I can see the slide. I can see. Okay.
And from that hospital, baby was referred to the another hospital.
Proceed.
Okay.
Previous slide.
Baby was referred to another hospital. There.
That slide I cannot see. Previous. Okay. Next one.
No. Is it visible now, sir?
Yes. This slide. Okay. This slide. Slide is jumping. Previous one.
Lakshmi.
Previous. Yeah. Then what happened?
The connection.
Then what happened?
Okay, after that, the baby was referred to another higher center. There, the baby was ventilated for 5 days. And on the second day, mother was informed that baby developed seizures, and mother did not know whether the sugar was low or not.
She was not informed about that. Okay, whether she's not sure the baby had hypoglycemia or not. When you say hypoglycemia, what is the cutoff level?
Less than 50.
Less than 50 or 40 on day 1. What is the cutoff?
Less than 40 on day 1.
Less than 40 on day 1 and subsequently 50. Okay, then proceed. She does know whether baby had hypoglycemia or not. Then
Jocelyn? History of jaundice on day 3. Yes, sir.
Yeah. Did you ask about the group? Did you ask about the one second? Somebody is calling me frequently. Hello.
Lakshmi.
Hello. Did you ask about the group of the mother? So it's very important to ask about the group of the mother, because you know that if the baby is saying jaundice, then people ask question, what is the reason for this jaundice? Now you cannot answer. What is the group of the mother?
B positive, sir.
What is the cause of the jaundice for this baby?
It could be sepsis, Bartha.
How do you know that? How do you know that? How do you know that? You didn't ask the group of the mother and group of the baby also?
Mother blood group, mother B positive.
You should ask about that. You should ask about that. What are the causes of jaundice in a newborn baby? Usual cause of jaundice in a newborn baby. How can you say it's because of sepsis? You cannot say like that. It can be because of incompatibility. It may be due to sepsis. So what type of jaundice you get in sepsis?
Sepsis can produce cholestatic jaundice
and direct hyperbilirubinemia. You are not sure. So you are not sure. It's very important to ask about the group of the baby, group of the mother in the second trimester. You proceed. Does baby had jaundice? The cause we don't know. Anyway, baby was put on phototherapy. So do you put babies on phototherapy if it's due to sepsis?
Yes, sir. If it is due to
Yes.
sepsis also,
Yes.
you have to start antibiotics.
Yes. No, you answered my question. Do you give phototherapy for direct hyperbilirubinemia?
No, sir. No.
No. Yes. Okay. Then proceed. So anyway, so most probably it might not have been due to direct hyperbilirubinemia. Maybe might have been due to indirect hyperbilirubinemia. Proceed. Then what happened?
And baby was started on expressed breast milk.
So till that time, baby was not on breastfeed. Till that time, baby was not on direct breastfeeds. And
yes, sir. No, he was ventilated for 5 days.
And they said baby had seizures. Seizures developed on which day? First day,
on
day 1, day 2, day 3.
Day 2.
This baby developed on day 2,
sir.
Day 2. This baby developed the seizures.
Yes,
baby
sir.
didn't cry after birth. They are not sure whether they have given resuscitation or not. But baby had seizures. Whether any description of these seizures, what type of seizures that you expect in a newborn baby?
It can be subtle seizures.
Then other types of seizures that you expect can occur.
Myoclonic seizures.
Myoclonic seizures. Then
abnormal other like lip smacking, cycling
those things
movements.
are subtle seizures. Those things are subtle seizures only. You have told me myoclonic seizures, subtle seizures. Other types of seizures the newborn baby can develop.
Generalized tonic-clonic seizure is rare in a newborn.
Very rare. Okay, why?
Because of the immaturity of the nervous system.
Could you please say a little more scientifically?
Decreased myelination.
Okay, impaired myelination and synaptogenesis. Then other types of seizures? Tonic seizures. Focal chronic seizures. And multifocal chronic seizures. So baby can have focal chronic, multifocal chronic, and then tonic seizures in addition to myoclonic seizures and subtle seizures. Anyway, you are not sure which type of seizures this baby had. Anyway, you are quite sure that baby had seizures on day 1 or day 2. You are not sure. How significant it is, a baby having seizures in the newborn period? Is it significant? So, is it important? Yes, that's a very serious thing, especially if the seizure is continuous. Anyway, proceed then.
Yes. And after baby was shifted to mother's side on day 12, and day after shifting,
before that they have given express breast milk, where the baby was they have given only express breast. So baby was not sucking and swallowing directly from the breast.
5 days baby was on ventilator, and mother, remember, for few days they have asked for express breast milk, and before just shifting the baby to the mother's side, just mother did not remember correctly. Baby was they were sucking well at breast, and hence baby was shifted to the mother's side on day 12.
On day 12. So the baby was on ventilator for 4 days, and then which
5
day
days.
they have given the baby to the mother?
After 7 days after extubation.
At that time, baby was sucking the breast or not?
When the baby was just few days before baby was given to the mother's side, baby was sucking well at breast.
Okay.
And after shifting also, mother tells that the baby was active and sucking well, and except for there is an increased irritability and poor sleep, mother did not notice any other abnormalities in the baby.
She couldn't recognize any seizure abnormal behavior.
No history of any abnormal movements, feeding tolerance.
Then what happened?
Then baby was on IV antibiotics and discharged on 3rd week with some oral medication.
The baby was on any anti-epileptic drugs. You said baby had seizures.
Yes, sir. The baby was discharged. When the baby was discharged, baby was given some oral medication for seizure.
Any idea about the type of medication they have given?
Mother doesn't remember the medication.
Okay, so which are anti-epileptic drug you prefer to be given to a newborn baby?
Phenobarbital,
Phenobarbital,
levetiracetam.
levetiracetam. Among this, which anti-epileptic drug you prefer?
Phenobarbital was.
Phenobarbital. Why? But people say that phenobarbital can cause neuronal apoptosis. So it can sedate the patient. It can cause, suppose the baby is on phenobarbital and the baby develop bleeding after 7 days or 10 days or 15 days. Which complication this baby might have developed? Is late SDN is a complication?
Yes, sir.
Okay. So that means so left to me, I will prefer levetiracetam over phenobarbital. So phenobarbital sedate the patient. It's very difficult to feed the baby. The baby is on phenobarbital, especially the baby had HAE and all that. Okay, then proceed. Antibiotic stopped after 2 weeks and MRI. Okay, then they have imagology was done. Proceed.
After discharge, at home, baby was sucking well at breast, and mother noticed there was increased stiffness of four limbs, both limbs around 1 month, and there is history of irritability and decreased sleep.
Increased sleepiness. Maybe due to phenobarbital. Okay.
No, sir. Decreased sleep.
Increased sleep or decreased sleep?
Not sleeping well at night, according to
no,
history.
And increased sleep or decreased sleep? Decreased sleep. Okay.
Decreased sleep, sir.
Proceed.
History of occasional nasal regurgitation of feeds was present. No history of any poor feeding, vomiting. No history of lethargy. There was
whether
no history suggestive of any
time, whether baby was on direct breastfeeds or not?
Yes, sir. Baby was on direct breastfeed only.
Could you please tell me the breastfeeding advices that you should give to the mother? Breastfeeding counseling.
The baby should be okay. And before in the antenatal time itself, mother should be advised regarding the benefits
but I agree. Postnatally.
Postnatal, mother should be advised about the mother should be aware about the qualities of breast milk and the importance
no. Tell me the practical aspects only. Don't essays or theory. Qualities, immunoglobulin and all that. Practical aspects of breastfeeding.
Okay.
How will you counsel the breastfeeding technique?
We should show the mother how. Okay, show the mother how to position the baby.
Tell me where exactly should be the position of the head.
Okay. The head and back should be on straight line, and the nose of the baby should touch
exactly the position of the head while feeding.
The head should be.
Head should rest at the palm or elbow.
Head should be at the elbow, and mother's buttocks should be supported by the palms.
And the baby's two hands. You need both hands for feeding. You need only one hand for feeding.
We have to support the baby with one hand, and the other hand, the mother can adjust the nipple.
Position the nipple. Okay, proceed. Then
position the nipple.
After feeding, what is the most important advice that will give?
We have to advise the mother to properly bath the baby. And the mother should be taking adequately 2 liters of water per day.
What will you do? Suppose the baby
vomits. To continue breastfeeding.
The baby regurgitate or vomit. What will you? What is the advice that you give?
Advise the mother to stop feeding and turn the baby in left lateral position.
Or head down prone position. Okay, proceed.
There was no history of any abnormal smell of body or urine. There is no history of any deviation of angle of mouth, ptosis, no history of any abnormal eye movements. Vision and hearing was normal according to mother's history. And mother gradually noticed difficulty in changing
diaper. Male child or a female child? Male child.
Male child.
What did you ask about the urinary stream of the baby?
Urinary stream was normal according
to. What do you mean by that? Why is it
important
to ask about the urinary stream of a male child? Why is it important? 1 second. Why is it important to ask about the urinary stream of a male child?
Posterior urethral valve.
Suppose there is a posterior urethral valve. What is the urinary stream?
The child should wet the thighs when he passes the urine. It will not pass at a distance.
width of the urinary stream?
It should be less. Child has to apply some push and
So good. So it should be good volume and good width, and it should pass at a distance, and it should not stop in between. Okay, proceed. So the urinary stream was good for this patient. All patients you have to ask about urinary stream, especially male children. Okay, then.
Okay, sir. And mother gradually noticed a difficulty in changing diapers. And by 4th month, she noticed that the baby is not smiling at her, or there was no head control attained.
At what age baby is supposed to smile to the mother?
At
Maximum.
2 months.
What is this known as?
Social smile.
What is the afferent pathway of social smile?
Optic nerve.
Optic nerve only?
Eighth nerve. Hearing the sound.
Eighth nerve. So it's social smile is an important milestone in the natural history of human beings. Why is it important? What's the relevance of social smile? As you said, vision should be intact. Vision means the entire pathway should be intact. What do you mean by that? So that means your cornea, your iris, your vitreous, your retina, your optic nerve head, tract, radiations on the occipital cortex. And what is the efferent pathway?
Smiling. 7th nerve.
Only 7th nerve? So if only 7th nerve is involved, you will get only a rhizus sardonicus smile.
5th nerve also.
5th nerve. So when people smile, other than 7th nerve, which part of the brain is involved? Now I am smiling, you can look at me. There is an emotional component. Emotional component. Which part of the brain is involved in emotional component?
Sensory cortex.
No.
Frontal lobe.
No, limbic system. So that's present only in human beings. Only human beings can smile. Advanced part of the brain of the anybody in the any all living objects. So things. So limbic system is involved. So it's go from this occipital cortex goes to the limbic system, and then through the facial nerve the smile occurs. So in other words, social smile indicates the integrity of the entire brain. You can almost so that means you can reassure the parents that this child's mentation is going to be normal if baby is able to smile before 56 days. So whether in this case social smile was delayed, any delay in social smile after 56 days is worrisome. Isn't like that? Baby smile only at the age of 4 months only. Is it like that? Jocelyn?
Yes, sir.
When does the social smile happen for this baby?
It was coming, sir. It was happened only at 10 months, sir.
10 months, my God. Gross delay. That means, so what's the inference?
There is gross
now,
development.
At this point, you can swear and say that this child is having severe mental subnormality. Almost sure that child is having severe mental subnormality. Okay, then proceed. Social smile happened only at the age of 10 months. Then?
At 4 months, the child was taken to a pediatrician, and he advised to start.
Only at the age of 4 months, child was taken to a pediatrician. Before that, they have not. Because you are supposed to take the baby to the pediatrician or to the healthcare worker at 6 weeks of age. Isn't like that?
No, sir. Baby was in between. Baby was on follow-up from the newborn NICU hospital, and baby was gaining adequate weight, and mother was taught stretching exercises.
No. So you are supposed to, yes, you have told me that they are following the baby in the newborn care, but you are supposed to show a child to a pediatrician or to a healthcare worker at the age of 6 weeks. Isn't it like that?
Yes, sir.
At 6 weeks, what are things that you look specifically?
We have to, as it is a high-risk newborn, we have to be very
When a baby comes to you at the age of 6 weeks, what are things that you look? Higher risk or low risk?
To look for a developmental assessment should be done.
Okay, what do you mean by that?
At 6 weeks.
How much this baby's birth weight is 3.1 kg. So what's the weight that you expect for a baby at 6 weeks?
Initially, baby will gain 200 grams per week for the first 3 months.
No, please tell me what's the weight that you expect for a baby at the age of 6 weeks. 6 weeks means 42nd day. Birth weight was 3.1 kg.
Around 5 kg.
What's the calculation? Tell me the formula.
Okay, age in months
Can you apply that?
plus 9 by.
Can you apply that at the age of 6 weeks?
Yes,
When will the baby regain birth weight? Take baby regain birth weight on which
at the
day?
10th day.
10th day. That means 42 minus 10 is
32.
32 into how? What is the weight
20
gain
gram
for
per
the
day. Minimum 20 gram per
minimum
day.
20? Usual. What is usual?
30 to 40 gram per day.
30 grams per day. 30 grams per day. That means 32 into 30 means 960 or 1 kg. So 3.1 plus 1 kg is 4.1 kg. So you expect a weight of 4.1 kg. What was any idea about the weight gain of the baby at 6 weeks? Then, other than that, what are the things that you look at when the baby comes for at the age of 6 weeks?
At 6 weeks, at ventral suspension.
No. First of all, you say the measurements that you expect at the age of 6 weeks.
Okay. 6 weeks. The length should be around 55 centimeters.
Okay. The head circumference. Do you measure head circumference when the baby comes for follow-up?
Yes, sir. We have to measure the head circumference.
Yes. What is expected head circumference at this age? The length of the baby is 55. What is the head circumference that you expect?
We have to use the Dines formula.
What is the Dines formula?
Age by 9.
Age?
Sorry. Length by 9.
Length by 9.
Dines formula. Length by 2 plus 9.5 plus or minus 2.5.
Length by 2 plus 9.5. Then which value you get? You're correct?
Length by 2 plus
50th centile. You'll get the 50th centile. Then if you add 2.5 to that, you will get the
head circumference.
No, 95th centile. If you subtract 2.5, you'll get the 3rd centile. So head circumference should be around this 50th centile plus or minus 2.5. Then okay, like that. Then what is the other thing that you look when the baby comes for follow-up at the age of 6 weeks?
We have to look for the angles, like any adductors.
You are interested only in neurology, routinely. That part I agree. For a child who had a HAE, who didn't cry immediately after birth, you have to look for that. Routinely, normal baby come to you at the age of 6 weeks. Which other system you examine? There is no jaundice for the baby. Banu Karamla is there. He may be hearing. He is always looking for jaundice, color of the emotion. He wants yellow color and clear urine. He doesn't want the pale stool and high colored urine.
Whether the child is following at 6 weeks.
Okay, then
at 45 degrees.
That's good. Then any other system you want to examine with your stethoscope?
Cardiovascular system.
Why? At what age shunt lesions usually manifest? Present?
Once the PDA closes after 2 to 3 weeks.
PDA?
I'm sorry. Shunt lesions.
At what age the resolution or the pulmonary vascular resistance happens usually?
After 1 to 2 weeks.
Usually 6 weeks. So when they come for follow-up, you have to auscultate the heart to know whether they have a shunt lesion or not. What's the commonest shunt lesion that's seen in a baby? Proceed. Not connected with this topic.
VSD.
VSD is correct answer. You proceed. So those things you have to look. So anyway, so this baby was shown to the pediatrician at the age of 4 months only. Then what happened?
Yes, sir. And there is no history of any no history of nasal regurgitation. History of nasal regurgitation was present occasionally from the initial 1 year itself, and child attained partial head control by 9 months, and baby was recognizing mother by around 10 months. There is no history of any regression of attained milestones. And by 9 months,
you are telling me the developmental history of the child, or are you going to describe the developmental history at a later time separately?
Developmental history is coming, sir. Developmental quotient is coming. By 9 months, baby had an episode of seizure. That was a tonic-cloning. Mother remembers it as a tonic-cloning movements of both upper limb and lower limb. That was lasted around for 15 minutes. And baby was taken to nearby hospital. And mother does not remember the events correctly. But at the time of discharge, one more anti-epileptic was added. And child had another seizure of same semiology at the 4 years. Cost of drugs high. From 9 months to 4 years, child was seizure free, and child did not attain any milestones after 9 months.
This child had continuous seizures irrespective of the anti-epileptic drugs. So anti-epileptics was added one by one. Right now, this, how many anti-epileptic drugs child is getting?
Sir?
How many drugs child is getting now?
Two anti-epileptics.
Two anti-epileptic drugs. So what you told me that child didn't attain the milestones after 9 months of age. So child has attained some milestones. What are milestones child has attained by 9 months?
Sir, normal development, sir.
Normal development, I don't know, up to 9 months.
I didn't get the question, sir.
So what are the milestones child has attained by 9 months of age?
Okay, 9 months, child attained partial head control, and child was recognizing the mother.
Only that much. The child was able to turn over, child was able to sit with support, without support, stand with support, stand without support.
No, child was not able to stand or sit with support. And, he was made to sit with the support of pillows. With other support only, he was able to sit.
Fine motor aspects.
There was unidextrous wrist. He was approaching the objects with one limb by around 6 to 8 months. And he was able to transfer objects from one hand to another.
The child was able to transfer objects from one hand to another. Because by none of the milestones child attained. Severe delay. So what is the developmental question that you for this child? Gross motor, fine motor?
It was all developmental milestones are less than 10%.
Language.
There was cooing at the 4 months, and child laughs loudly since 6 months and able to produce inappropriate sounds since 4 months with a developmental quotient less than 10.
Now, is child able to say words or sentences?
No, sir. No, only he's able to produce
severe delay. Okay, then yes, gross motor, fine motor, language, social and adaptive behavior, nothing.
Social smile was present since 9 months.
Only social smile is present. No other milestones. Okay,
no other milestones.
Okay, so that means your overall assessment of the child regarding is less than 10%. Eh?
Yes, sir.
Okay, then which other history you have taken?
Immunization history. Child is fully immunized till age.
As per the national immunization schedule?
At birth, BCG, OPV, hepatitis B. 6, 10, 14 weeks, OPV, pentavalent.
Well, Pentavac was there at that time, 8 years back.
Oh,
I don't know at which age, but that age where Pentavac was there. They might have taken DPT.
She did. He didn't show. He only told that it was completed.
Then you have to ask. You have to divide the schedule not specifically. Other they might say something. Then
so no optional vaccines were taken.
No. So if you suppose if you have facilities, they can. Which are non-NIS vaccination you advise to a child up to 5 years of age?
We can advise pneumococcal vaccines for this child. Meningococcal vaccine, influenza.
Meningococcal vaccine do you give routinely in our country? No, people are not giving meningococcal vaccination routinely. But other non-NIS vaccinations people are advising. What are other non-NIS vaccinations you advise to a child? At what age you can use influenza vaccination, and from what age onwards you can give vaccine against typhoid?
After 2 years.
No, you can start giving vaccination against typhoid from 6 months of age.
Influenza vaccine can be given
from?
Okay.
From 6 months of age onwards. Then, what are the other non-NIS vaccinations that you can advise?
Varicella vaccine.
At what age you advise varicella vaccination? At what age you advise varicella vaccination?
Varicella vaccine can be given at any age, at a gap of
early age. I am asking about the early age.
6 weeks.
No, never. You are advising varicella vaccination first dose at age 15 months. Okay, and second dose at 4.5 years. Then vaccine against hepatitis A from 1 year onwards. Okay, and then you didn't say about nowadays you are giving Rotavac also. Government is giving Rotavac. So you can use 3 doses of Rotavac. Now it's in the day of the national immunization schedule. But vaccine against conjugated pneumococcal vaccination and vaccine against influenza, vaccine against typhoid, vaccine against varicella, and booster doses of conjugated pneumococcal vaccination 15 months of age. And then in government setup, they are not giving booster dose of H influenza type B. That also can be given. So there's a preparation known as Codrovac. So that contains DPT plus HIP that can be given at the age of 1.5 years. Okay, then we can give booster dose of varicella, not booster dose, second dose of varicella at 4.5 years. And then in government setup, you're giving MR and MMR at 15 months, but in private setup, they are giving MMR or MR at 9 months and then 15 months and 4.5 years. Okay. And then 10th year, if you can afford, which are vaccines you give to your child?
This pneumococcal vaccine, meningococcal.
No. 10th year, you won't give pneumococcal vaccination to a child who has already taken. They have taken all the vaccinations, and 10th year, which vaccine you advise?
Sir, I didn't understand, sir. Till?
What is the vaccination of choice? Which are vaccination you will advise to a child at the age of 10th year?
Who is not previously vaccinated, sir?
Previously vaccinated.
10-year TT.
Not TT. TDAP.
HPV.
No.
TDAP.
So
TDAP.
I used to say to my people who can afford kanji, they have to take TT. If they can afford a rice meal, they can take TD, and they can afford a biryani, you have to give TDAP.
Okay, sir.
Advise only TDAP if people who can afford. And in addition, you can have to give vaccine against human papilloma virus for boys and girls.
Okay, sir.
For boys and girls, you have to advise HPV vaccine. So TDAP and HPV vaccination has to be given at the age of 10th year. Okay, I proceed.
Dietary history. He's getting 1,314 kilocalories against the required calorie of 1690.
This is not sufficient.
And
you have to give the detailed dietary history in the sense that breakfast, how much calorie that is there. Okay. So you have to make a chart like that. So breakfast, lunch, and dinner, calories on seconds, and protein. The aim is to know whether you know the nutritive value of the various Indian food items. So this is not sufficient.
Okay, sir.
This is not sufficient. So on the left side, time. Second is food item. Third is quantity, and fourth is calorie, and fifth is protein. And that then you have to write vertically rather than horizontally, and then make it a chart, and then you add. Okay, this is not sufficient.
Okay, sir.
Protein, I can. It is there. Protein is there. Okay, proceed. So, what is expected calorie intake for this child?
1690 kilocalorie and 29 gram protein.
How old is the child? Okay,
coming to family
bedside formula is sufficient. That means 1,700 current. There are no point in saying 1,693.4 grams. 1,700 is okay. How much protein?
Okay, sir. 29 gram.
4, 5, 6, 10, 10, 34 grams. It's 8 years.
Yes, sir.
8 years.
8 years.
Okay. What percent of calories should come from protein?
70% of the calories from carbohydrates. 50 to 60 from 50 to 60. No, sir. I am telling less than 10% from protein.
15 grams. 15% of the calories should come from protein. 50% from carbohydrate, 15% from protein, and 35% from fat.
Fat.
Okay.
Family history, it was a non-consanguineous stage. No family history of any neonatal or infant death. No history of any bedridden children. No history of any mentally retarded children. No history of any blindness or deafness in the family.
So what was in your mind when you asked this question of blindness and deafness in the family? What was in your mind when you asked this question?
As the child is having developmental delay, any neurodegenerative diseases that runs in the families that affecting the white matter, that affecting the gray matter can cause blindness in the child.
Okay, that's good. That's good.
And there is no family history of any seizures, no history of any children with a developmental delay in the family.
Okay, proceed. Okay, then environmental history. This is a family history you have written. Nice. Okay, then economic history.
Socioeconomic history. Father is a driver. He's getting additional income from land with a total monthly income of 20,000.
Okay, in your history.
They are staying in a 2-bedroom terrace. Mother is not getting any incentives from any schemes.
Okay.
The ration card is white.
So there is no social support for this family. Is there any social support?
No, sir. He's not
that's
getting
sad
any.
because so these people need a social support, otherwise they can't manage. Okay, then you proceed. Next.
General examination. Child is conscious, spontaneous eye opening present, visible wasting present with a nasogastric tube in situ. Pulse rate was 100 per minute, regular, normal volume and character. Blood pressure was systolic, 90 millimeters, right upper limb in lying position. Respiratory rate was 28 per minute, regular, thoraco-abdominal, no intercostal drawings. And child was afebrile at the time of examination. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy or pedal edema. Coming to head-foot examination, head appears small. There is loss of hair in the occiput.
Why?
Head shape
Why
was
there is
normal.
loss of hair in the occiput?
Because child is chronically bedridden because of the pressure effect.
Yes.
The head shape is normal. There is no dysmorphic features. No neurocutaneous markers.
What are the neurocutaneous markers you specifically look?
Neurofibromatosis, tuberous sclerosis, Ashleaf macule, shagreen patches, adenoma sebaceum.
Neurofibromatosis, what are the markers that you look specifically?
Capellus spots. And any
what is eye manifestation neurofibromatosis?
Niche nodules.
Okay. Sturgeon syndrome, hemangioma. Okay, then proceed. No skin ptosis, nystagmus.
No skin ptosis, nystagmus, no cataract.
No. So that's a good thing about the cooperative medical college PGs. They always look the fundus. So my PGs never look the fundus because they are ashamed, and they say that we are ashamed to look the fundus. But so I saw this cooperative medical college students carrying ophthalmoscope, and they use the fundus. That's a good thing for cooperative medical college students. I would like to congratulate for that. Okay, then you examine the fundus and it's normal.
It was grossly normal, sir.
Okay, that's enough for the pediatrician to know whether there's a papilledema present, any cherry-red spots present or not, or was any evidence of any intrauterine infections present or not. Only that much is sufficient for us. Okay, then.
There was no ear discharge, no deviation of angle of mouth, drooling of saliva was present. Child had dental caries, angular cheilitis was present. There was no thyroid swelling, no rachitic changes. Genitalia was normal. Contractures was present at both angles.
Both testicles are present in the scrotum.
Yes,
both
sir.
testicles are present in the scrotum.
Yes, sir.
The glands is visible or not? Penile hygiene is good or not? You didn't look. Why? It's very important to look the external genitalia of male children to know whether testicles are present or not, whether penile hygiene is good or not. Otherwise, they may be suffering from phimosis. So you have to address these things. Should not be ashamed because it's our duty to see the external genitalia of male children. Okay, then.
Then contractures were present at both angles. There was no bed sores.
Okay.
Anthropometry weight is 15 kg.
Expected.
Less than
Expected.
24 kg at 24
What is the formula?
kg.
What is the formula?
Age plus 4 into 2.
No.
After 7 years, age 7x minus 5 by 2.
And then why do you say like that? So 8 years, 56, 25.5 is expected. You said 24. How can I say it's 24? 25.5 is expected.
Okay, so.
Then
height is 120
you
centimeter.
measure the height of a bedridden child.
We have to measure the segmental length and add.
Then why do you say height?
Length.
You wrote height. Height is different from length. What is the difference between height and length?
Okay,
Which is more?
Length is more.
How many centimeters? Length is more by how many centimeters?
1 to 2 centimeters.
No, 0.7 centimeters. So it's a segmental length, and then you have to add and then say. Yes, Marine Prinda, 0.7. Okay.
And the head circumference was 48 centimeter. It was less than 3rd centile in the WHO growth chart, microcephaly.
When you listen
the head circumference of the mother.
Chart degree, when you listen microcephaly, than that, what is expected head circumference for this child?
Around 52.
52.
As he is 8 years.
So below what percentage you say child is a microcephaly?
Less than 3rd centile on the.
3rd centile, or what percentage? Less than 7.5% expected. Less than 7.5% expected. Okay, so you measure the mid-param circumference. I won't find fault with you because this child is a malbidden, even though it's people say that 6 months to 5 years, but I don't find fault with you if you have measured the mid-param circumference 14 centimeter. That's okay. And then there is microcephaly present for this patient. Then
yes, examination of the central nervous system, higher mental function.
No, not like that. Not like that. So sixth heading is developmental assessment that you have done early. That for that matter is okay. But the headings on which you have to present general examination of a child are: 1, comment about the patient; 2nd, vital signs; 3rd, pickle; 4th is head-to-head examination, and 5th is growth assessment, and last one is developmental assessment. So this child you have already done developmental assessment that you can include as a in all cases. Suppose if you get a case like this short case, then you have to do 6th heading is developmental assessment. Anyway, this case you have already done. So which system you examine? CNS first. Okay, then why do you examine the CNS for this patient? This child is having fast breathing. Why do you examine? So this is a chronic child. Why do you examine CNS first?
But as I examined the child on
what is the acute problem?
At that time,
what is the acute problem? Vomiting and fast breathing. Then why do you examine the CNS of this child? Why do you waste your time? So you have to see the what is the problem for this child is fast breathing. So fast breathing, you have to examine the respiratory system first, not the CNS. ഈ കൊച്ചിനെ നിങ്ങൾ കാഷ്വാലിറ്റി വന്നു കഴിഞ്ഞാൽ CNS നോക്കി ക്രെയിൻ നോക്കി കൊട്ടിക്കൊണ്ടിരിക്കുകയല്ലല്ലോ ചെയ്യുന്നത്. അവർ ഇമ്മീഡിയറ്റ്ലി അവർ examine the respiratory system, see whether the child is having pneumonia, see whether the child is having decreased air entry, increased or any crackles, wheeze or bronchial breathing. That you have to look rather than examine the cranial nerves, looking for reflexes, looking for the sensory system, looking for plantar. That you can do later. So the system that's going, so in acute patients you have to give priority for the systems. First you send the respiratory system first or GET first, and then you go to the CNS.
Okay, sir. Examination of the respiratory system, inspection, trachea appears to be center, no accessory muscles of respiration working, movement of chest wall equal in all lung areas, there is no drooping of shoulder, no supraclavicular hollowing, palpation, trachea appears to be central, chest movements bilaterally equal in all lung areas, percussion, normal resonant note in all lung areas, auscultation could not be done.
Why?
Sir, we were in PP, sir. Child was COVID post.
Oh my God! Sorry. This child is COVID positive.
Yes, sir. Actually, this child was a suspect. Child was COVID negative, but as he was suspect, he was sent to us.
Okay. So that means
at the time of
otherwise, you have to examine the respiratory system. You didn't. Okay.
At the time of at the general examination, the child had no tachypnea, sir, and child was maintained for 7 days. For us, for
no, it's not like that. So this is a different situation now. But you know that in treated pneumonia, respiratory may be normal. So it's you cannot. There is an excuse for not auscultating. Treated pneumonia, there won't be any tachypnea, but still you may get findings. You may get crackles, wheeze. You may get bronchial breathing sometimes.
Yes, sir.
So that's not an excuse. So for tachypnea, you have to examine the respiratory system of each and every patient. That is not an excuse. Okay, if there is no tachypnea, I didn't examine the respiratory system is wrong. I didn't auscultate, that is wrong. You have to auscultate the respiratory system area by area, focus area by area in all patients. So that's not an excuse. But this COVID and all that, I don't know, because once you wear the PPE kit and whether you can auscultate I don't know that. Otherwise, you have to auscultate each and every patient. Okay, even newborn babies, even crying children, you have to auscultate. Yes. So, any findings in the respiratory system on auscultation? No, you didn't auscultate. GAT.
Gastrointestinal system. There was no hepatosplenomegaly.
No. It's not like that. It's the way in which you are presenting GAT.
Okay. Oral cavity, dental caries were present. Inspection.
Mucosa, any evidence of vitamin B complex deficiency for this patient?
There was
cheilitis.
There was angular cheilitis present. Tongue appears normal. No mouth, no after ulcers. inspection of the gastrointestinal system. There were no scars, sinuses, or no abdominal distension.
Fullness distantly, every chance of malnutrition. Ascites present in abdomen distended or not?
No abdominal distension.
Movement of the abdomen.
All quadrants of abdomen move equally with respiration. On palpation, there was no tenderness, no local rise of temperature, no hepatosplenomegaly. There was no shifting dullness and no mass palpable. Percussion, there was no fluid thrill. Genitalia was normal. Bilateral testis descended.
Okay. Then you go to the CNS.
Child was conscious, lying in bed with both up flexed at elbows and lower limbs flexed at thighs, knees, and ankles. Spontaneous eye opening was present. Child was looking at the mother, and he's laughing loud and makes some inappropriate noises. Examination of cranial nerves. First cranial nerve could not be tested.
Okay.
Second cranial nerve, meniscus reflex was present in both eyes, and he is reaching for objects on both sides. Third, fourth, sixth cranial nerves, movement of eyeball found to be normal in both quadrants, and there was no squint, no ptosis, or no nystagmus. Direct light reflex was present in both eyes. Accommodation reflex could not be tested. Trigeminal nerve, there was no deviation of jaw, no wasting of temporalis muscle. Seventh nerve, there is no deviation of angle of mouth. Eye closure was found to be normal. No obliteration of nasolabial fold. Eighth nerve, he turns look towards the side of sound on both ears. Ninth and tenth nerve, no history of nasal regurgitation present. Palatal movements could not be tested.
How will you assess 9th and 10th nerve?
9th and 10th should be ideally assessed by the movement of palate. And in nasal quality of sound.
If there's a lesion of 9th and 10th nerve, what happens to the movement?
Position of the
same side or the opposite side?
Same side. Same side.
Seventh nerve?
Opposite. There will if it is an element palsy, there will be deviation of angle to the opposite side and absent of.
10th nerve?
9, 10, 11.
What is 10 plus 7?
Okay, opposite sides. 10 nerve to the
same side. 10 plus 7 is?
17.
What is 10 plus 7?
17.
What is 10 plus 7?
10 plus 7 rule. 10 and 7 to the opposite side.
10 plus what is 10 plus 7? 17. What is 12 plus 5?
Sir?
You don't know the arithmetic. What is 12 plus 5 and what is 10 plus 7?
12 plus 5, 17.
12
plus 5 to the same side.
So 10 plus 7? Okay, so that is a
10
tip.
plus 7 to the opposite.
That is the tip. Okay, 10 plus 7. So 10 and 7 towards the?
Opposite side.
Yes, okay, then. No wasting of articulations. Okay, then.
Examination of the motor system. Bulk, there was symmetry in both sides. Right side, upper limb, both 14 centimeter. Lower limbs 18 centimeters. Tone was increased in both upper limbs and lower limbs. Upper limbs had a grade 3 power on both sides, and lower limbs had a grade 2 power on both sides. Superficial reflexes.
Will you get muscle power?
Grade 0, no power. Grade 1, there is flicker of movements. Grade 1, grade 2, there is passive movements only. And grade 3, against grade 0, no power. Grade 1, flicker of movements. Grade 2, just passive movements eliminating gravity. Grade 3, against gravity, but not against resistance. Grade 5 is against resistance.
Proceed. So, then
superficial. Superficial reflexes, corneal and conjunctival reflex could not be tested.
Why?
Because the mother was very anxious about.
Mother is very anxious, so that means she. Okay, then.
Then abdominal reflex was absent. Plantar reflex, bilateral extensor. jaw jerk was absent. Gag reflex could not be assessed.
There is no brisk jaw jerk.
No, sir.
Then
Deep tendon reflexes, biceps, triceps, and supinator were brisk on both upper limbs, and knee-jerk was brisk on both sides. Ankle, there was clonus present in both angles. The primitive reflexes were absent. Sensory system, the child was responding to touch and pain in all in face, chest, and abdomen. And cerebral signs, there was no nystagmus, no pendular knee jerk, and gait could not be assessed. Skull and spine, there was scoliosis present. There was no tuft of hair, no spinal dimple or dermoid.
meningeal signs.
Meningeal signs were absent. No meningeal signs.
You have not ordered. Only when I asked, then only you have told me, because I have to say like that. Otherwise, once you have to say or you have to write, but both are not there. Only when I ask, you say there is no credit for that. Any bruit?
It was not auscultated, sir, again because of the
because of the COVID situation. So otherwise, you have to auscultate for look for a bruit also. So then proceed. Summarizing.
It's an 8-year-old boy, non-case of global development delay, fully immunized with no significant family history.
You cannot say fully immunized. You can say immunized as per the national immunization schedule. Immunized as per the national immunization schedule. You cannot say fully immunized.
Okay, sir. Okay. Immunized according to the national immunization schedule with no significant family history, with a history of perinatal asphyxia and seizures on day 2 of life, with a history of ventilation for 5 days, with a no developmental regression, now presented with vomiting, fever, and acne of short duration of 1 day. On examination, the respiratory system at the time of examination, child was.
So, what is the most important thing that is lacking in this summary? This child has not attained any developmental milestones that you didn't mention. That's the most important point. How you mentioned that?
Global development.
Oh, that is okay. That in that is everything is good. Okay, then agreed. Okay, global development. Okay, then. But when you have proceed, then with these findings, what do you think?
It could be a static encephalopathy.
Static encephalopathy.
Probably spastic quadriplegic cerebral palsy. Etiology, probably birth asphyxia with a GMFCS grade 5. Aspiration pneumonia, microcephaly, undernutrition, and GERD.
So why do you have static encephalopathy?
Because there is no history of any progressive disease in the child. There is no history of any regression of milestones. And there is no worsening of the initial condition of the child. And this
my question is that, so why can't it be because of an intrauterine infection?
And there is no significant antenatal history of any fever with rashes, no history of any maternal pyrexia, and the child is not SGA, no history of any IUGR.
And because of rubella? Is rubella is a possibility?
Yes, sir. If the mother had fever with rashes,
whether this child is any of the clinical features of rubella syndrome?
No, the child is not having any cataract. Hearing is normal according to our examination. So there is no deafness.
What type of heart lesion that you get in rubella usually?
Most common is pulmonary stenosis. VSTs.
Or PDA. Okay, so there is no organomegaly. And what are the other types of intrauterine infection that may be other than rubella? Can be because of CME infection?
Cytomegalovirus infection can cause chorioretinitis, cerebral calcification.
But you examined the fundus, you couldn't see any evidence of any chorioretinitis.
No, there was no evidence of any chorioretinitis.
So you are not suspecting any, because in the context of HAE for this patient, birth weight is 3.1 kg, the chance for intrauterine infection is unlikely. Isn't like that?
Unlikely.
Birth weight is 3.1 kg. In case of intrauterine infection, the birth weight will be low, small for gestational age, isn't like that? This baby's birth weight is 3.1 kg, so intrauterine infection is unlikely for this patient. Can be because of chromosomal anomaly. I am telling that
chromosomal
only. You said static encephalopathy, but I am telling can be because of chromosome anomaly.
The chances are also lesser because the maternal age was not high at the time of maternal age was not.
Other than that, any other clinical features?
There is no any dysmorphic features.
That's good. So there is no features.
The baby was born out of a non-consanguineous marriage.
That's good. That's good. That's the most important clinical point. There are no dysmorphic features for this patient. So unlikely because of a chromosome anomaly. Okay, and then can because of any other inborn error of metabolism. You said.
Again, it is again unlikely, sir, because there is a significant history of HI, and again the baby is born out of a non-consanguineous marriage, and there is no history. Even not started after starting feed. There is no history, or there is no significant history of hypoglycemia, feed intolerance, or recurrent vomiting.
You have told me that there is no abnormal smell of the urine. You have
no
told me the
abnormal
history.
smell. No abnormal
these are
smell
point against the diagnosis of inborn error of metabolism. So from the history, it's most probably because of a static encephalopathy, and the cause for this because of the birth asphyxia baby might have suffered. And what is the reason for this birth asphyxia? Because I know you said there is a prolonged labor, and also there is leaking PV, but that is 16 hours only. So whether whether baby had any chance for sepsis? Can you suspect sepsis in a newborn baby?
Early onset sepsis, if the baby is having tachypnea, most common sign may be tachypnea after birth, fever, poor feeding, lethargy, hypoglycemia, obstructive jaundice.
Could you please, I lost connections in between. Could you please say once more?
Okay, sir.
When you suspect sepsis in a newborn baby?
Early onset sepsis should be suspected in any baby who is complaining of with a significant passes leaking PV, with maternal UTI, prolonged labor, and if the baby is having poor feeding, hypoglycemia, poor activity,
what is the most important clinical
hypothermia.
Feature? What is the most important clinical feature of newborn sepsis?
Tachypnea.
Correct.
Tachypnea.
So this baby, we are not, but this baby didn't cry immediately after birth. So, and you think is it because of the factors? What is the reason for this problem? Antenatal factors, natal factors, or postnatal factors?
The problem
this baby
could
had
be
prolonged labor.
Prolonged
you
labor.
Yes, prolonged labor, and there is application of forceps also.
Yes, sir. There can be intrauterine asphyxia.
So baby might have
fetal hypoxia.
So what are the measures now whether baby had intrauterine problem or natal whether they have done any fetal heart rate monitoring was done?
The mother does not remember about the fetal heart rate monitoring while she was in labor room, but she remembered that it was done at the last visit. That is a third trimester it was done, and it was said to be normal.
Labor, whether the fetal heart rate was
mother is not aware. Mother is not aware of that.
Sure. So your belief is that baby might have had some problem during delivery time.
Delivery time.
So that is the reason for this baby's problem.
Asphyxia. Yes, sir.
Okay. Is it a meconium staining of the like?
There was no history of any meconium stain like.
Any history of any cord around the neck?
No history of cord around neck.
No history of cord around the neck. No history of any. You said now the significant problem for the mother in the antenatal period. All problems started in relation with the natal period.
Second stage of labor. Yes, sir.
In labor only. Okay. So your diagnosis, what is the commonest cause of cerebral palsy? Is it because of antenatal factors or natal factors or postnatal factors?
Antenatal.
Is it because of antenatal factors always?
It can be 10 to 15% of the causes can due to birth asphyxia. Others
only very less, not very high. So most of the cases of cerebral palsy is due to factors not connected with the delivery. Okay, then you said why do you say quadriplegia?
This is a four-limbed CP with almost equal involvement of both upper limbs and lower limbs.
So what's the difference between spastic quadriplegia and double hemiplegia?
Double hemiplegia is a four-limbed CP with more involvement of upper limbs.
That's correct. Okay, so your diagnosis quadriparesis with global development delay, severe mental retardation, and etiology of basaxia, GM of CS5, and now you're suspecting pneumonia, microcephaly, and so why do you suspect GERD for this patient?
Because the mother is currently telling that even after putting the Riles tube, the child is having some abnormal expressions while feeding, increased difficulty while feeding, and cough after occasional cough after feeding.
Syndrome. Are you suspecting Sandifer syndrome?
It can be, sir.
The common this. So the child is getting recurrent choking
Cough.
episodes. The child is having any
Cough
cough. Huh?
Yes, sir.
Cough while feeding.
Yes, sir.
You said that is so. Are you in favor of pseudobulbar palsy for this patient?
More in
You
favor
didn't
of
get any
pseudobulbar
brisk
palsy.
jaw jerk, but you didn't. You
But
said
there
you
was no
didn't
brisk
get any
jaw jerk.
brisk jaw jerk. Did you
sir.
touch the patient at all?
Yes, sir.
Yes, but you cannot auscultate. You didn't auscultate, but you touched the patient. You can you elicited reflexes, but you didn't auscultate. Yeah, why? Why is like that?
ചെയ്യാൻ sir മറ്റേ ഇത്
Oh, yes, okay.
difficult.
Then, so any imageology required for this patient? Any investigations required for this patient?
As it is, he is having a significant birth history. We don't need not evaluate the child for other neurodevelopmental cause of neuroregression, and we can check the baseline investigations like we can look for any anemia, blood count, HB, thyroid status. And we can take an EEG if the seizures are not properly controlled.
That's good. You have to take an EEG and see whether seizures are controlled or not, electrical activity is still present or not. Okay, based upon that we can manage. Then, any MRI is required for this child? Is any point taking MRI right now?
Sir, actually, we are not suppressing. We are not suspecting any degenerative disorder.
Oh, that's good answer because there is no already taking B. So diagnosis
we have
clinical
no any
investigations.
diagnostic
Now there is
dilemma
no point taking MRI and wasting their
at
money.
this stage.
Okay, that part I agree. So now, what are things that you can do for this patient?
Okay, sir. We have to approach this. We have to do a multidisciplinary approach for this child. And first of all, we have to register the mother in Ashwasagiranam scheme for bedridden children. And she can get an incentive of 600 rupees per month.
Oh,
and
that's good.
she's totally and she's totally unaware of that. And we have to connect the child with the nearby Anganwadis. And the mother should be known what to do when the child is getting seizures, or when to bring the child to the hospital. And child should be made arrangements for the proper cleaning and proper replacement of
so how do you know that regarding the seizures child is getting, you have to see the dose of this anti-epileptic drugs child is getting. What is the name of the drug? Are they giving it regularly? Is it a drug default present or not? So those things also you have to address. Isn't it like that?
Yes, sir.
Which anti-epileptic drugs child is getting now?
Child is getting levetiracetam.
What's the dose?
At 40 mg per kg per day.
Oh, child is getting that.
Yes, sir.
Okay, then with that also seizures are controlled or not?
It was controlled, sir.
Any other anti-epileptic drugs child is getting?
Levetiracetam.
Valproate? Child is getting valproate?
I think it was other. I forgot, sir. It was valproate, I think.
That's very important to know whether a child is getting this anti-epileptic drugs properly, whether the dose is correct or not, whether they give whether it's a sustained release preparation or other preparations. There are also things here. A child is getting any multivitamins along with this?
Yes, sir. So the child is getting vitamin D and multivitamin syrup.
Which vitamin D? How much?
He's giving it is 1.5 ml, some 400 by 1 ml. 600 units.
Child is getting vitamin D. Okay, then so the epilepsy part you have to control. Then what about the feeding?
Yeah.
You said
feeding as
how are they giving this feeding? Through the you said rice tube. What are feeding they are? What types of feeding they are giving?
They are giving semi-solid foods, ragi, kanji adichadu.
Are they giving fruits, fruit juices?
Occasionally they are giving fruit juices.
Are they giving probiotics?
Not adding any probiotics.
No, you have to ensure that child is getting all different types of food items, including fruits, vegetables, and also probiotics and carbohydrate, oil, etc. And then what about dental hygiene?
We can, the mother is doing chlorhexidine mouthwashes with the brush. And
are they giving proper gum hygiene? Are they rinsing the gum with the fingers?
She is using a brush with after removing the bristles.
Pressure alone is not sufficient. You have to make use of the press the gums with the finger.
Yes,
and then is there any whether this child requires any swallowing study to know whether the child is having swallowing difficulty or not?
According to history, there is some swallowing difficulty as there is increased.
So you can do the swallowing study for this patient, and if there is severe swallowing problems, child is having aspiration, you can advice.
Percutaneous gastrostom
Yes,
can be
okay,
advised.
or gastrostomy tube can be given. So that's the best thing to prevent aspirations. And then, do you want to give this empirical PPE for this patient? You said child is having GRD. You want to give this any? How will you exclude? How will you manage this GRD part?
It can be given by proton pump inhibitors.
Empirically can give, but other than that, documenting.
Ideally, we have to do the pH study by
pH monitoring, then
pH monitoring, 24-hour pH monitoring. And we can advise the mother about the proper positioning to feed the child in a head-up position. Hello? Sir, you are not audible, sir. Sir, കേൾക്കുന്നില്ല sir? Audible അല്ല sir? ലക്ഷ്മി കേൾക്കുന്നുണ്ടോ സാറിനെ?
Jaykumar sir, you are not audible.
കേൾക്കുന്നില്ല സാറിന്. Not audible, sir. കേൾക്കുന്നില്ല sir?
Sir, why don't you try removing the headphones and directly?
Hello?
Yes, sir.
Okay, something happened in between. I pressed somewhere. Okay, sorry. Okay. So, barium solo?
Yes, sir. Barium swallow can be done.
Hello? Now I cannot hear you. I can't hear you.
Hello, sir.
Oh, you're getting congratulations from Dr. Banu. He says that Jocelyn, you have done a wonderful job. There is a good appreciation. ഞാൻ കുറച്ച് ടഫായിട്ട് പറയും. ഞാൻ നിങ്ങളോട് ദേഷ്യം ഉണ്ടായിട്ടല്ല. only for your improvement. ഞാൻ ടഫായിട്ട് പറഞ്ഞാൽ നിങ്ങൾ എല്ലാം ശരിയാവാണ്ടിരിക്കും. But he's a very much concerned person, Dr. Banu sir, you know. Okay, and then so regarding GRD, you can empirical management PPA. Which PPA you advise? What is your choice?
Omeprazole.
Lansoprazole?
Lansoprazole, omeprazole. Lansol can be given.
And then how long will you give this lansoprazole? What about the diet? What diet you are giving? But in all in other children, you have to give thick and feeds. But this child, you know, because it's allowing difficulty, you are giving rice to feeding. Okay, then other management, other optimal management for this mobility. What are things that you can do?
The mother should be advised to change the position to avoid bed sores, and he should be advised about the stretch physiotherapies that can be done at home to reduce the spasticity.
Now valuable time is lost. Child is 8 years. Contractures already developed.
Yes, so mother may not be doing.
So it's a quadriparesis. So
yes,
do you advise drastic measures to reduce the spasm for this child, or you want what are things that you can do to control the spasm?
We can put the child on medications like baclofen.
How will you give baclofen?
0.2 to 2 mg per kg per
orally,
day. Orally.
Any other method of giving this baclofen?
Can be intrathecally.
But is it advisable for these patients? No,
because if you give intrathecal baclofen, the child will develop
very costly affair.
Fungal attacks.
This child with the quadriparesis, there is no point in baclofen. And how much you have to spend for this intrathecal baclofen?
It is very costly procedure, and
Lakhs.
again, child can develop adverse effects like truncal
Also, you have to
ataxia.
spend lakhs, nearly 5 lakhs, 7 lakhs, 10 lakhs, like that. So that's not advisable for this patient. Other measures, but not in this case, or other drugs that you can use. You can
Baclofen,
baclofen,
dandrolene, oral diazepam, and orthopedic procedures like tendon
Now, any other
releases.
drug that you know? Have you heard about tisanidine?
Tisanidine.
And then in case of diplegia, any other methods?
We can botulinum toxin.
Botulinum toxin. That's also a costly affair. How long? Whether botulinum toxin is a one-time affair?
Its effect will last only for 2 to 3 months, and we have to repeat
maximum 4 months only. Okay. So then that's for the spasticity. Then regular physiotherapy, and then other problems.
And we have to we have a multidisciplinary. We should have a multidisciplinary approach. We have to give good oral hygiene.
That you have told already.
Okay. And we have to manage his any orthopedic problems. That the mother should be advised to keep a pillow in between the thighs, so that it's a severe quadriplegia with the already contractures at the angle. So there's a chance of hip dislocation, and the mother should be advised about proper positioning, and the mother can be advised to support the head with the pillows, and proper positioning of the limbs, to continue physiotherapy, and to continue neurodevelopmental stimulation for the child. And we have to manage the other, if there is severe contractures, we can go for tendon releases. And if the child is having scoliosis, we can give spinal braces for the child. And we have to control the seizures. We have to adequately manage.
That you already told. Whether you advise wheelchair for this patient? Wheelchair with the head support? Electrically operated wheelchairs?
Electrically operated wheelchair, we can advise, sir. So,
and then suppose the mother asks whether any chance for improvement for this child with hyperbaric oxygen therapy. So what's your advice? So people advise hyperbaric oxygen therapy and all sorts of non-specific measures. Whether do you advise that for this child?
Since the child has passed already 8 years old, I won't advise.
There is not much there is no scientific basis for all those things. Okay, then what is the pathology that you expect in this patient and the brain?
As the child is having quadriplegia, he may be having multicystic encephalomalacia, parasagittal brain injury.
And
sometimes there can be any congenital brain anomalies.
Do you suspect congenital brain anomaly for this patient?
Not for this patient.
Whether do they have any other children? Only one child.
Only one child. Two children.
Other child is normal.
Other child is completely normal.
So the pathology that you expect in this patient are diffuse neuronal necrosis, multicystic encephalomalacia. So all this happened due to the asphyxia the child has suffered in the perinatal period or at the time of delivery. Okay, so that's about the pathological changes. There is no chance for this change and conversion of this to a normal brain. Microcephaly is already there.
Yes, sir.
So any other issues in a respiratory system? Any other problem can happen? Do you want? So this child is getting a vitamin D regularly.
Yes, sir.
Is it like that?
Yes, sir.
Isn't like that?
Yes, sir. Yes, sir.
So now what? So your duty is to prevent aspiration, control epilepsy, and
test physiotherapies.
Regular physiotherapy. You can advise an electrically operated wheelchair with the head support, and vision and hearing. Vision is there, eh?
Yes, sir.
Did you say anything about the hearing?
Hearing also normal.
How can you say normal? Did you assess the hearing?
Okay.
Have you done a BERA? Have you done a BERA for this patient?
Mother doesn't remember that. OAE was done at the neonatal period. About BERA, mother did not know.
OAE was normal.
OAE was said to be normal.
Normal. Okay,
no records available.
Then most important thing for this patient is prevention of aspiration. And for that, if you have some difficulty, you have to advise a PEG or a gastrostomy tube for this patient. And constipation is an issue. Whether constipation is an issue for this patient? Is it constipation?
No, he's not constipated.
He's not constipated. But you have to ensure that child is getting a regular fiber diet. So Thank you so much for the presentation. That is fairly good, and you covered almost all aspects. Only minor problems are there. Dr. Pramod.
Yes, sir.
Thank you so much. Any questions? Okay, then.
Dr. Jocelyn, please stop sharing your slide. Dr. Jocelyn, please stop sharing your slide.
Okay, sir. Okay. Okay, sir. Okay.
So thank you, sir. Thank you for the excellent grinding session. And this was an excellent presentation by Dr. Jocelyn. And I must mention Dr. Shaiji. Madam, are you here?
Yes, sir. She is very much there.
Dr.
Yes, sir. Yes, sir.
Madam, few words, because Madam is the person who thought about the idea about having a PG clinic. And
congratulations are flowing to Jocelyn. Congratulations are flowing. I can see from the chat, so many people are congratulating her for her excellent presentation.
So, Madam, a few words from your side.
Yeah. Actually, I really thank Dr. Narayan and also Dr. Pramod for initiating, because it just came to my mind all of a sudden that we also should have a teaching session, because there are so many PGs around the city. In the city, there are so many postgraduates, so they should be benefited. At the moment I talked to Dr. Narayan, he immediately said, I will speak to Dr. Pramod, and Dr. Pramod immediately called me. So everything was very quick. And I really thank you, and really thank Dr. Jaykumar sir. He's my teacher too, teacher of teachers. I really thank you also, sir. And I appreciate Jocelyn's presentation. I wish it could continue regularly on a regular basis.
Definitely, madam. We will be doing it. We will discuss in the WhatsApp group and decide on on how often we should do it. So,
yes.
So the next presentation is open to anybody, any PG other than cooperative Government Medical College, Kalamashiri.
Yes, sir.
And madam will be chairing the session. Correct?
Okay.
She's a mild person, unlike me, Dr. Shiji. I was with her at Copper. She's at College. She is a very mild person. She won't be. Is a mild person.
My PGs will not say that, sir.
So, sir, with that, I think my secretary is a little busy with this COVID. He's in charge of the COVID cell. I will propose a vote of thanks. I profusely thank Professor Jaykumar for conducting the excellent session, and Dr. Jocelyn for the fantastic performance in her presentation, and all of you who have attended. Thanks a lot, and good night.
So we should say thank you to you, Pramod.
Welcome, sir. Welcome.
And okay, and Cochin IAP. Thank you so much. May I leave?
So I am winding up the session. And PGs, kindly note that there is a YouTube channel called IAP Cochin branch, and there are a lot of pediatric potpourri sessions with multiple speakers of national and international repute with varying degrees of different topics in different systems. I request you to go through it, and this presentation has been recorded, and shortly it will be uploaded on the YouTube also. Thank you all. Good night.
Thank you, sir.